Okay, awesome. Perfect.
Okay, we're live.
Hello, everybody. Welcome to our Medicare for All and Coronavirus Town Hall. My name is Solomon Rajput. I'm a candidate for U.S. Congress in the 12th Congressional District for the state of Michigan. And today we are coming to you with a panel of amazing experts in all different fields, healthcare, health policy, who will be telling us about coronavirus and the need for Medicare for All that we've all seen given the pandemic that we're in. So today I want to introduce some of our panelists. I'll go ahead and say their names and their positions, and then we will hear from them in a little bit after I kind of give some introductory remarks. So we have Holly Jarman, Professor Holly Jarman. She is a health policy expert and a professor who will have a lot to contribute to this discussion in terms of policy. We also have Dr. Susan Gould, who is an expert on health policy as well, and she was going to talk to us a lot about allocation of healthcare resources and the need for Medicare for All when considering those perspectives. And we also have Marty, who is a nurse, and she's been in the thick of the healthcare experience with the coronavirus, and she can share her perspective as well. So, and I'm a medical student actually, so we have many people from many different backgrounds, and so I bring the background as a medical student. So I'm running for Congress as well, and so when I tell people that I'm a medical student and I'm running for Congress, everyone gets so confused. They ask, what is a medical student possibly doing running for Congress? And it's a great question, and I think I've got a halfway decent answer. So when I was younger, I was really passionate about politics. I was taking a look at our messed up status quo that we've got going on in our country, you know, from the cost of college to our climate change crisis, and of course, our broken healthcare system. And I was thinking, you know what, it'd be really good to do something about these issues. Maybe I'll get involved in politics to try to tackle some of these problems. But the more I was thinking about it, the more I realized, oh wait, actually, you can't count on the government to get anything done. They will literally never do anything because they're just bought and sold by big businesses. And I realized, well, there's no way in heck that I can sign up to be a shield corporation. So I realized, well, I guess this isn't for me. I'm out. And I guess I'm going to have to do something else then. And ultimately, I ended up in medical school because it's a way to help people when they're going through a really tough spot, as we have seen in the middle of this pandemic. And I was thinking, maybe we can change our healthcare system from the inside out. But now times are changing, and we have a whole new generation of leaders who are saying we're not going to be beholden to corporate interests any longer. We're going to go out there and fight unapologetically for what people in this country need for us to get done. People like Bernie Sanders, Ilhan Omar, Rashida Tlaib, AOC, and these people inspired me. And I was thinking, maybe if we get the right people in office, we actually can do something about these big issues for once, and we can address the issues of our time, like our healthcare system. And so upon a lot of reflection, I decided to run because I believe that the establishment has totally failed us. All they know how to do is to think small. But it's that same small thinking that's gotten us into this mess in the first place. I think by now it's clear to everyone that we can't just keep putting band-aids on our broken systems and expecting things to change. We need to go out there and fight for the big, bold policies that are going to address our issues at a fundamental structural level. So we've begged and pleaded with our politicians for a long time to go out there and fight for these big changes, but they've ignored us time and time again. And after a while, we have to realize that we can only beg for so long before it's clear that these people, they're never going to go out there and fight for what we need to get done. They are never going to change. So if we want to get this stuff done, we've got to go do it ourselves, because at this point, we're done waiting. And something that we are definitely done waiting on in our country is fixing our broken healthcare system. And so now that I'm running for Congress, many people have shared very, very heartbreaking stories that they and their families have experienced. And I want to relay some of those to you, because these are real people. These are real people who live in our district and are sharing the struggles that they've experienced with our healthcare system in America to me. And I think everyone should hear about these stories. So I was talking with somebody who is a sophomore at a local university in our congressional district, and she was telling me about her mom. And her mom was getting really sick, and they didn't have health insurance. So the mom said, well, there's no way in heck that I'm going to see a doctor because we can't afford that. So I guess I'm going to try to tough this one out. So she was trying to tough it out, but she kept getting sicker and sicker. And ultimately she got so sick that they had to go see the doctor because there was no other choice. They went to the doctor, and it turns out that she had waited too long. And this disease that could have been totally treated if she had been able to see a doctor earlier ended up actually killing her. And then to top it off, the family had to pay the medical bills for years afterwards because they were in so much debt. I have another story of a patient who was being seen by a friend of mine who's a medical student and another physician, and they had cancer. And so they went to see the doctor, and it turns out that they just lost their health insurance. And they told the doctor this, and the doctor freaks out. They're like, oh my God, what are you doing? Like, I can't see you if you don't have health insurance. And the patient says, doctor, please, I'm dying. I need this treatment. Can you please help me? And the doctor says, no, you don't understand. If I give you this treatment, if I do all of the scans and all of the tests that I need to do for you, for your disease, you will be overnight in tens or hundreds of thousands of dollars of medical debt. I can't in good conscience do that to you. So go figure out how to get some health insurance quickly, come back to me and I'll take care of you immediately, but that is the best that I can do for you right now. There's another story of a patient that I saw with another doctor. And she had a brain tumor. And this brain tumor ended up causing many seizures for her. And then those seizures, and one of those seizures made her fall. And so she fell and she broke all of her teeth. She broke her teeth and she went to go see the doctor for an unrelated issue, unrelated to her dental care. And she was telling us about how she can't eat anymore and she has to drink all of her food through a straw. But she has health care, but she doesn't have dental care. And she can't afford a dentist. And she was trying to figure out some way to pay for her treatments, but she was not able to figure out any way to do that. And so she was on the cusp of writing to Ellen or to Oprah or to someone in order to have them bring her on her show as like an example of a charitable moment in order to have her dental coverage taken care of. So when we hear about these stories, when we hear about that woman who died because she wasn't able to go see a doctor because her healthcare was not, because she didn't have healthcare and she didn't feel like she could afford to see one. You know, it's not an exaggeration to say that that woman in particular died at the hands of our broken healthcare system. Because if she had gotten sick in any other country, there's a really good chance that she'd still be alive today. Because what has every other country done? They've been able to figure out how to make healthcare a human right. That's just a fancy way of saying, if you're sick, you should be able to see a doctor. If you're sick, you should be able to get your medicine. That's all it's saying. And so when we're asking for something like Medicare for all, especially in the middle of a pandemic, healthcare for everyone, nothing we're asking for in this country is radical. We're just trying to play catch up with the rest of the world. The radical thing is insist that we can't do this, that we're too uniquely incompetent or incapable or dysfunctional or backwards to get this done. The radical stance is the status quo. And I think at this point, it's becoming increasingly apparent that it's barbaric. And we're done waiting on our politicians who keep making excuses for why we can't do what the rest of the world already has done. And that is particularly true in the middle of a pandemic. Why is it that the United States of America, now the most powerful, richest country in the world, has the most coronavirus cases in the entire world? Why is it that our response has been so laughable, so uncoordinated, so meager in relation to the responses of countries that have a fraction of our economy and our resources? There are no good answers to these very simple moral questions. And discussing the failure of our government and the failure of our leadership and the establishment is something that we will be discussing today, in particularly in relation to the coronavirus, and thinking about the need for Medicare for all. So on that note, I'd like to start bringing on our speakers. So I'm just going to introduce them again and then open up the floor to them, and then they'll be able to share their thoughts with you, a little bit about their background and their perspective. And then we're going to move on to the next panelist after that. So I'd like to start off with Professor Holly Jarman. And she brings a wealth of knowledge in terms of policy and the impacts of policymaking, politics, and the governance and our governance on health outcomes. So Holly, please feel free to take it away.
Sure, thank you so much. And thank you for inviting me to speak today. So I'm in my day job a professor at the University of Michigan. I study health policy. I'm not representing the University of Michigan today, but I hope I can bring some of my own personal and professional perspective in. And as you could probably tell by my accent, I'm originally English. I'm an American citizen now. And I actually do that in my work. I study health services and systems in other countries. And so, yeah, I very much relate to the discussion about coverage and access to care and how that varies by country. And the good news is we do know what works in other countries and health systems. We have a pretty clear idea of some of the things that we can do to make our health system better, and some of the lessons we should learn from other countries, some of the things we should not learn from other countries not to do too. So hopefully I can talk a little bit about some of those things as we go through our session today. And especially for me, it's all about thinking about universal health coverage as discussed by countries around the world and by the WHO actually. We're talking about allowing everybody to access care. We're talking about everybody being able to access good quality care and doing that without financial hardship. That is the definition of universal health coverage that countries have agreed upon together. And so there may be some ways that we can think about this in the context of the US healthcare system, but also the US public health system, and some of the flaws of both of those systems today have been emphasized by what's happening with COVID-19 and the US response as compared to some other countries. The US has not necessarily been performing very well in this regard. And a lot of countries have had some failures, but we do know that countries like South Korea that have been testing very extensively in their population, and countries like Germany, where they've been doing what we would call contact tracing and good surveillance work, trying to figure out who's been exposed and then who their contacts are, so that they're tracking the virus more carefully. Those are things that those countries have accomplished in a better way than we have. And so we really should be learning from their practice, I think. But those are the kinds of things I can maybe talk about and unpack as we go through today.
Absolutely. Well, thank you so much, Professor Holly Jarman, for that introduction to some of your work and your expertise. And we are going to have a very spirited discussion that your perspective will be very helpful for after our introductions from all the panelists. So looking forward to that. Next up on our list is Dr. Susan Gould, who is a medical doctor and also spends a lot of her time thinking about health policy and working on health policy related research as well, from the University of Michigan. So Dr. Gould, feel free to take it away. I believe you are on mute right now, Dr. Gould. Okay,
yeah,
perfect.
I just fixed that, thanks. Thank you for having me. Thank you for inviting me to this. And I want to echo what Professor Jarman said. I'm not speaking for the University of Michigan. My background is, as Solomon pointed out, I'm a medical doctor, an internist. That's like a pediatrician for grown-ups. And I also have a background in health policy and economics and in philosophy, where I emphasized the study of justice. So most of my scholarly work and some advocacy and policy work has been in the area of health equity, and in particular, getting voices heard of minority and underserved communities in health policymaking, particularly when it comes to deciding how to spend limited resources for health and health care. I think that the COVID-19 crisis has really brought to the fore a lot of the disparities that were present already in our health care system and in our public health system. That is, that people of low income and minority race and ethnicity have worse health than others. And since I've, just told you I've been studying fairness and justice, that's just blatantly unfair. Okay, that by accident of birth, the color of your skin or the size of your pocketbook would determine how healthy you could be. So, those of us working in the health equity space, whether as researchers, public health leaders, policymakers, or clinicians, have both brought attention to health disparities and how those have affected the pandemic, health disparities that existed before the pandemic and that have been exacerbated by it, much to our shame. And there are a lot of questions about why particular populations may be doing worse. For instance, African Americans. Is it their pre-existing health? Is it their essential worker roles or front lines? And a lot of questions we don't know the answers to yet, and hopefully we'll learn over time. But I think one of the things that many folks I know working in health equity have said, let's not let this go. Let's hold on to this. It's got attention from the public and from the media that poor people and minorities are worse off, are doing worse. They're getting infected at a higher rate and they're dying at a higher rate. And that's wrong. And let's keep the attention on that, even when, hopefully, the virus pandemic is mitigated. I'm not going to say when it's all back to normal because it's going to be a long time before we're all back to normal. So, but I would challenge us to think not just about Medicare for all, which I know Solomon has been spouting a lot, but the more you spend on health care, the less you may have to spend on public health. And there are a lot of things that affect health besides health care. So yes, it's wrong that some people have access to care and some don't based on money. Totally agree with that. Couldn't agree more. But I think we also need to be cognizant of the fact that the cost of care is a problem, and that if we want to have strong, robust public health, which is even more important for things like this pandemic, but it's important for lots of other reasons too, we need to make sure that we don't spend it all on healthcare. So there are trade-offs. This is the basics of economics. You can't have it all. So what exactly for all is a good question. Some of the things we've seen in the pandemic also that affect people's risk and health, do they have paid time off? What kind of housing do they have? How many people live together in one home? How many bathrooms do they share? Can they self-isolate? So there are a lot of things that affect health, and this pandemic has really magnified those a great deal. All right, I'll stop, and I look forward to questions.
Thank you so much, Dr. Gould, for pointing out that it is absolutely very unjust and very unfair, the fact that low-income people and many communities of color, many vulnerable populations are being so disproportionately affected by the coronavirus pandemic. And we absolutely should not just forget when this pandemic ends, hopefully one day, we should not just forget about those disparities and treat them as business as usual. We absolutely need to keep fighting for solutions that will make our health outcomes equitable across different demographics. So I completely agree with you on that, and I'm looking forward to discussing that with you in much greater depth during the discussion. Beautiful. And our last, but definitely not least panelist, her name is Marty, and she is a nurse who has had a tremendous amount of firsthand experience in this coronavirus situation that we got going on right now. So I'm really excited about having her on this panel as someone who's part of the front line, and having her discuss her perspective. So Marty, please feel free to take it away.
Thanks a lot, Solomon, and thanks for having me. As you know, I'm a nurse in Philadelphia, and I'm speaking actually for a friend who's a nurse in Michigan, but who didn't feel safe speaking out on a video conference like this because they've already faced harassment, intimidation, retaliation from their employer. But they thought it was really, really important that a Michigan story get told as part of this conversation. And I'm sure you all know, but that Wayne County has the 7th highest rate of corona positive cases in the whole nation. And the system is very overwhelmed. And it's particularly overwhelming in the intensive care units. Those, we always take care of critically ill patients in the ICUs, but it's on a whole different level. And as your previous speakers have already mentioned, also this is a new virus. There isn't a vaccine. There's, like 10 studies going on at any one point in the ICU, trying to figure out what does work, what doesn't work. These patients have incredible needs. They're very, very sick. Everyone's heard about the need for ventilators. What people might not have heard is how much they also need dialysis, kidney replacement machines. And of the 19 in the whole hospital where my friend works, 10 were on her unit, of her 20-bed unit last week. Like, that's just how critically ill the patients are. And because we were short on the personal protective equipment that also has gotten in the news, particularly the N95 respirator masks, those tight-fitting masks that protect the wearer from the virus, that healthcare workers are getting sick, healthcare workers are dying, and then there's not as many healthcare workers on the front line. And so we're added to the crisis of the virus, and the patients is added to a staffing crisis where we just don't have enough nurses to take care of these patients. And they're bringing in nurses from different specialties to help us in critical care areas, which is, really hard on them. It's hard on the patients, and it's hard on the critical care nurses because they're also trying to help these other nurses that don't have current skill and ability to take care of patients who are quite that ill. So at the same time, that there's all these patients and they're so incredibly sick. There's also healthcare corporations who are closing facilities, who are furloughing employees, and it's just going to further exacerbate. And it's all based on, zip code and where patients have the ability to pay. There's no lack of need for health services. There's just lack of ability to pay for them. And that's something certainly that Medicare-for-All would address. But I think that the crisis is also exposing, as your previous guests have said, like a deeper crisis in healthcare, not only from the patient's side, but from the healthcare workers' side and from the system side, that we need to kind of eliminate profit as the underlying driver of the system, because that makes people make decisions based on money instead of what patients need. So obviously it would be better if my friend who's a nurse in Michigan could speak today. I think that patients are safest when healthcare workers are protected and have the ability to speak out about what's going on in their facilities so that they can be addressed. If we're threatened with discipline or even termination for speaking about what patients need, those patients aren't as safe as they would be if we were absolutely free to speak out. And, even if that means critiquing our employer, We need to be able to do that. We need to be full-on patient advocates because we know what they need. We're at the bedside, and yeah, patients are safest when your nurses and your other frontline healthcare providers can speak out and say what's wrong and what's needed.
That's great. That's absolutely great. Thank you so much, Marty, for giving your perspective as a nurse on the front lines in this, in the middle of this epidemic. And I couldn't agree more. We need to be listening to the voices of the people who are the ones interacting with the patients and knowing their needs. And at what moment what moment is more necessary than the one that we're currently in to be receptive to the feedback of nurses so that we can be nimble and address the concerns that they have, because the concerns that they have are very serious in that it will affect patient outcomes and the health and safety of their own workers. So I couldn't agree more with you on that. I'm looking forward to actually discussing the role of the frontline workers and some of the disparities and the lack of resources that they've been given as a consequence of this pandemic. So thank you so much to our panelists for introducing themselves. So now what we will be doing is we will be going through a couple of questions that are very pertinent to the coronavirus and the need for a system that ensures healthcare for all people, like Medicare-for-All system. But to start off, we're really just going to start talking about the coronavirus, the state of the coronavirus right now, and the state of the coronavirus, particularly in our great state of Michigan. And I'm going to open up this question to any of the panelists. So anyone feel free to jump on in. And if someone has something to say at the end of what someone else says, please feel free to do that. And this will be a lot more conversational. And then when we're kind of done with one topic, we'll be going on to another topic. So to start off, I want to begin by saying recently, as we all know, there's been a lot of debate over the models used to predict the spread of coronavirus in Michigan. And as a result, there have been varying reports on whether or not Michigan has reached the peak of the coronavirus outbreak. Governor Whitmer has said that the outbreak is set to peak at the end of this month, but other models, in particular the IHME one used by the White House that is very popular in the media, they claim that Michigan peaked last week. So I'd like to ask the panelists, what are your thoughts on these conflicting reports, and how is it impacting our ability to effectively deal with this crisis and flatten the curve?
Sure, I have thoughts. So I think models are important because they look forward and they try to help people who have to make tough decisions figure out what resources are needed. However, a model is only as good as the data that goes into it. And part of the issue here is that we don't necessarily have the data that we might need, particularly sort of making tough decisions about opening up the economy is going to rely on understanding better who's had this, which means thinking about testing, thinking about surveillance more broadly and our capacity to do that really well. And so I'm a bit concerned about the focus specifically on the model because especially in the federal context, I think the Trump administration and Trump himself have kind of used this to play into some of the blame shifting discussions that's been happening. And kind of the idea that this is about states and states need to step up here, which is a theme we've heard in various of these discussions about opening the economy, testing, about ventilators, about essential equipment, which is disappointing and a bit of a shame. I think we should be focusing on trying to get better data so that we can make good decisions, because what we want to avoid is opening up the economy too soon and then having a second wave cause significant problems. And so a lot of countries are looking at how to do this right now. I can tell you that no two countries tend to have the same plan for how to do this. And in part, the politicians' reactions have been to focus locally, think about the data that works in local areas, but nobody has the best answers, I think, yet. We're still, I see countries still working on this really hard this week. So.
Yeah, I think I echo your thoughts, Professor Jarman, about, models are only as good as the information you have. And when you're dealing with something like a novel coronavirus, you're, you don't have good data. Hopefully your information and the knowledge that you need to take appropriate actions, whether that's medically or in public health, hopefully that improves over time. But you have to make decisions even without it. And the mitigation decisions made by policymakers early on, including our governor, I think have really helped flatten the curve and keep our hospital. I mean, at Michigan Medicine, we were expecting to be completely overwhelmed based on early models. And as time went on and it seemed to flatten a bit, that made a huge difference in our ability to take care of people in critical care in particular, but in the hospital at all. Meanwhile, losing money hand over fist, but that's, just doing our job. So that is, I think, garbage in, garbage out in terms of data. I think the most crucial piece coming next is in testing. That if we want to get back, not necessarily to normal, but to some semblance thereof, we need to know who has been infected, who is infected, and if they're infected, be able to have them self-isolate, which may mean providing things like hotel rooms for people, which has been done in some localities, because you can't self-isolate if you have a family of 6 living in a 1-bedroom apartment. So I think the testing and tracing is the key next step. I think our models, helpful though they have been at making sure that we did prepare for surges, that without really knowing how many people have been infected, you don't know what the mortality rate is. You don't know how easily it spreads. It seems to be spreading very easily, but we need to do testing and tracing. We need to do testing and tracing. Now, who do we test and trace first? I would argue is a really important question about justice, fairness, and equity. And we should probably start in the worst hit communities. And by that, I don't just mean geographically, I mean nursing homes and other institutions, prisons. And that's, I think, where we need to start, because that's where we need to know. And by the way, not just the people who live there, but the ones who work there.
So, Solomon, I don't know a lot about models. I'm a bedside nurse, but I know that my colleagues in New York City are living out a very different model than those of us who are living in other cities, because on the whole, like, COVID timeline, when they got the social distancing and the stay-at-home orders in New York was very much further along the line. More people were already infected and getting sick by the time those orders came in New York than when they came in other places. We were learning from that model. It's not a mathematical model, it's an actual, life-size model or whatever. And that just as the doctor before me said, that the stay-at-home orders and the social distancing have to a degree flattened the curve. And we haven't seen quite the same surges 90 miles south of New York and Philadelphia that they've seen. And obviously there's still epicenters around the country like Wayne County. And so if people could just keep in mind that this is still a new virus, it travels between people very, very easily, because I have two coworkers in the oncology infusion unit. They should have been the most protected nurses in the entire institution because they're dealing with a very immunocompromised population. And so they are very, very careful about everything in that unit. And two of them got put out on quarantine sick. One of them's been out for more than 2 weeks. She hasn't been back yet. She's very, very sick. And that just never should have happened. Yeah, all those patients should have been safe in the oncology infusion area. So the very things I am highly, we don't have a vaccine yet. It's a new virus. People are still testing out what works best, you know, early ventilation, not early ventilation. There's probably 10 studies going on right now just in my hospital about what drug regimen works the best. And it's just not time yet to completely flip and let everyone do whatever they want because of the economic pressures. I mean, we have personal protective equipment, but we don't have enough of it. And we're using it still against the manufacturer's regulations. You know, we're reusing masks that should be single use only. Where we have nurses working in the ICU that are much more comfortable working other places. We're already overwhelmed. We don't need to bring about the worst predictions that a surge could be by reopening the economy far too soon and too fast. It's working. Please, we don't need more patients. That's the last thing we need right now is more patients. We need to get the ones we have well and out of the hospital and back to their families.
This is Susan. I wanted to pick up on a couple of things that you said, and first of all, even the entire state of Michigan is really not is not well served by a single model. Okay, so what's happening in Wayne County is different than what's happening in Genesee County, which is really different what's happening in Alcona County and Marquette County. And I think we need to acknowledge that and respond with policy that makes sense so that we don't have a bunch of people from Wayne County going up to Barraga County and bringing a lot of infection. And we recognize the much less capacity for meeting a surge in demand in rural America, in rural Michigan. Okay, so it's not just about whether you have insurance coverage. It's also, do you have workforce? Do you have facilities? Do you have respiratory therapists? Okay, so I think we need to recognize that we can't really just talk about Michigan or even a particular county. I think we need to really recognize that it's different in different places, that the surge is different in different places. This is something where we don't have a treatment that works. We don't have a vaccine. We don't even really know enough about how it spreads. So on the other hand, I think that, you know, keeping everybody in lockdown for 6 months will have a lot of bad health consequences, okay? And probably already has been having bad health consequences for people, okay? Believe me, I am not one of the people who was in Lansing the other day demonstrating the COVIDiots. But I do think that we might think about, okay, what about people who do work where they're pretty much isolated? I mean, I actually went to my office Thursday morning because I was having connectivity problems at home and I needed to do telemedicine. Okay, well, you know, it's really hard to do telemedicine if you're not connected very well. So I went to my office. There was one other person on my entire floor. Believe me, we were quite socially distant. So is that okay? How might we allow some work to happen, important work to happen, and happen safely, right? So, I mean, we worry about PPE for healthcare professionals, but believe me, the grocery store workers are also on the front lines and they're not getting much. So I think we need to recognize that this pandemic is geographically different. New York City is different from Philadelphia, is different from Detroit, is different from Grand Rapids. Okay. It doesn't mean that, I mean, basically it's in almost every county in Michigan now at some level or another. Okay. But very different in Alcona County or Sheboygan County than in Wayne County. So how can we recognize that? And how can we improve health, which is dramatically affected by education, which the kids aren't getting right now, and by income, which a lot of people aren't getting right now. So these are hard questions. I'm not saying I have all the answers. I'm just bringing.
I think you did right in terms of the need for recognizing different places need different kinds of solutions because their problems are slightly different. At the same time, though, people need to make tough decisions to try and coordinate what localities are doing. So what we're kind of seeing with different states around the country making different policy choices is because there's a leadership vacuum federally, and that's causing problems because we're all interconnected. Our economies are connected. People travel. We move around a lot within the United States. So we don't want to see that same situation happen through in Michigan, for example, with different communities going different ways. So for me, as a person who studies policy, like coordination is key, planning is key. And so we need people to talk about and recognize the justice implications of this, the distributional implications of making these decisions about who gets a test, how do we figure out, given limited resources, where the resources to put our limited resources in order to get the best effect. And that requires local solutions, but also coordination across those localities to make sure we're acting together. We have to step up and kind of talk to one another and work as a state. And so
I couldn't agree more. I think the sort of centralized planning, and for instance, you know, as the things flatten out in some areas of the state, we may want to send workforce and equipment other places that get surges that don't have it, right? I mean, I think that's the kind of thing that needs that sort of centralized coordination.
Yeah,
Now we ain't getting at the federal level, despite
for sure.
FEMA's
For
mission.
sure. No, absolutely. I completely agree with everything that has been said. And I think it's been so interesting, you know, Dr. Gould mentioned the COVIDiots out in Lansing. Unfortunately, Michigan keeps being in the news for not the most flattering reasons. And I had so many people from across the country texting me like, what's going on in Michigan? How I can't believe there's a protest happening where people are like near each other without masks. And I'm like, believe me, we feel the same way. And the model, like we said, it's as good as the data that goes into it, but also a model can change based off of the response that the government takes, right? And so we want to, those very grim, dire models that we were seeing in the beginning that New York definitely was experiencing, we don't want those outcomes. We want to make sure that we intervene to prevent that catastrophic exponential growth that would overwhelm our healthcare capacity, like was predicted for the University of Michigan here in Ann Arbor. And the Governor Whitmer taking very dramatic and strong action to flatten the curve here in Michigan. It does seem to be helping to a noticeable degree. But then I think what's really interesting is how then some people in the public perceive that this whole thing was overblown because it was not, we didn't have the huge amount of deaths and catastrophe that could have happened if we had taken no action. So I think it's a really interesting question around messaging, like that I think that some people like Dr. Fauci and Dr. Fauci, like one of the only good things in the federal government right now happening, but some other health policy makers and public health advocates are saying, like, we want this to seem kind of like anticlimactic. Like, that's the whole point of everything that we're doing right now. Like, that was too much. And I think that public messaging needs
That's the goal.
that, like, we are so dramatic in what we do that actually we end up not having this catastrophe of deaths, because the models were initially indicating that way. And it's clear that can happen because of what we've seen in New York, very close to where Marty is working. So, but I think
public health, right? So this is normally the problem with public health. If things work well in preventative medicine, public health, we solve problems before they get incredibly severe. Right. So unfortunately, what happens is because people's, like, the visibility of those public health problems is not as great if we're really doing our job, and we pay attention to public health at the point in which we have a real crisis, unfortunately. And in other times, we tend to neglect the extent to which we really do have to invest in consistent surveillance, consistent screening, consistent public health programs, and preventative medicine in a much bigger way in order to prevent the big crises. And so we, as an ordinary public, we tend to pay attention to crises and not so much attention to the normal everyday work that the public health system does to stop crises from really getting out of control in the first place.
Yeah, absolutely. And that's, I think, precisely why we need more people who have backgrounds in healthcare, in science, who understand that the goal is to not be the hero of the moment and, like, address a crisis when it gets to be like a catastrophe for the purpose of publicity, but really to have a coordinated plan in place and the resources already budgeted for in order to prevent problems before they get really out of hand, which we've seen done in other countries, but definitely not ours. So, and I wanted to talk about something else that you guys mentioned, that I think all three of you mentioned in our discussion so far, which is just figuring out which communities are getting what resources. And so in particular, the media's talked a lot about the allocation of resources and how some communities seem to have good access while others have barely any access. So do you believe that these reports are accurate and complete, and in the sense that there's a disparity in terms of what communities get access to what resources? And if that does seem to be the case, what kind of factors help determine if a community has access to testing or other resources?
That last question, I'm not sure anybody can answer. I mean, I think one of the problems is that the lack of coordination, particularly at the federal level, has been for the purpose of testing resources, which I think all along has been an important resource and will remain an important resource going forward. That the lack of, upping manufacturing or getting the supplies needed or whatever has been a travesty, really. The lack of PPE, for instance, and ditto. One of the reasons why people are dying alone in the hospital is because of lack of PPE. If we had plenty of PPE, their family could be in there. But we don't have enough. And you do need somebody to take charge and figure out who needs what and who gets what, okay? And I think that you need to recognize that pre-existing inequities often come into play. So for example, if you make access to treatment or vaccination or testing or whatever sort of a first come, first serve basis, you will make it less fair because people who know about things, who can get places, who have access to both knowledge and transportation, therefore will get things first. And that's wrong. Shouldn't happen that way. So do you only send tests to the neediest places? Like I talked earlier about testing in nursing homes and in the Detroit area. I think there's a rationale for doing that, but there's also a rationale for going someplace like Kalkaska, okay, and testing everybody. And whoever's positive then saying, okay, quarantine, and doing it again. Because you can then actually contain something, as long as they don't like travel too much. You can contain, you may be able to contain the infection in the rural parts of the state by doing something like that. So I think you have to be able to balance those things, and that has to come from the state government.
Solomon, I would just add that on a much smaller scale, going sort of healthcare facility to healthcare facility as a frontline worker, in my experience, unionized facilities, that workforce was much more able to push administration to manage this in a much safer way. Like the fact that we have PPE, have adequate PPE, there's like a huge space between there, right? And so just because the CDC said, that's good enough, that surgical mask will do you just fine for a week, like it's not true. That's not scientifically based. And we were able to stand our ground. And even without the CDC to back us up, which is the CDC's job to be giving scientifically based standards for the industry, which they weren't doing. You know, they were basing them off of what employers needed, not off of science, not of what healthcare workers and patients needed. But we were much stronger in our ability to push at our employers and say, just because the CDC says that doesn't mean it's good enough. Good enough doesn't mean, or better than nothing isn't good enough. And we need you to keep trying for better and better and better. Get us what we need, or, you know, there's going to be consequences. And the same thing is true about the staffing, that we were much better able to manage all that pulling nurses in and out of their areas of specialty, and to keep patients safe and make sure that nurses were doing what was in their current skill and ability, rather than getting pulled into a specialty where they didn't have the expertise to manage that ventilator and all those sorts of things, and not furloughing workers that didn't immediately have work because they performed elective procedures, keeping those people on, keeping them paid so that you could use them in some capacity when the surge came, whereas other hospitals immediately laid off or furloughed staff and then didn't have that ability, or didn't want to bring them back, didn't want to spend the money to pay to train them to do other things, etc. So on that very small scale, I feel like a big factor is how secure the frontline workers are in pushing back against management, how without fear of losing your jobs or being disciplined, saying this isn't good enough, we need better, keep trying.
Can I say a profound advantage of Medicare-for-All would be a substantial drop in the administrative expenses in our healthcare system?
Yes, definitely, I agree.
Absolutely. And a certain element of a plan and coordination, which we completely don't have now, where even within the same healthcare system, everybody's robbing Peter to pay Paul, like going to one hospital's supply area and stealing it for this shift for this other hospital down the street, and then you don't have it, and back and forth. Just it would eliminate some of the chaos, or bring the chaotic level down a little.
So yeah, in terms of the supply of not just PPE, but also things like ventilators, and looking forward in the future, thinking about the supply of vaccines, competition here is not our friend, right? We need to be coordinating and figuring out the distribution of these needed materials. And so unfortunately, within the United States, you see there's competition between states for some of the same resources. Within our healthcare systems, there's competition. And then at the country level, you see competition amongst countries to try and get manufacturing contracts and buy up stock. And unfortunately, what we really need is better coordination internationally, nationally, and so on within the system, so that we are using production capacity within our own country, which is something that the federal government has the ability to do. And I don't think they've really made enough of that. And they should be planning going forward to make more of that production, and their ability to ask companies, and if necessary, coerce companies to manufacture needed resources. And that's going to be very important, for example, when we get to the stage where we do have a vaccine. And if we want to make sure there's enough and we can manufacture it quickly enough and have some kind of hope at an equitable distribution of that vaccine, we should be considering the production capacity that we have and making that plan just in the same way we should be now, not just considering ventilators, but also thinking about PPE or anything else that we need.
Swabs. Swab. Can I say, by the way, that I just want to make sure that we keep our feet on the floor when we talk about a vaccine, that it may or may not continue to work against the coronavirus as it changes and mutates. So we know that the coronavirus itself is slightly different in the US than it was in China. It's different in Michigan than it was in Washington. And I don't want us to spread the word that all we need is a vaccine and then everything will be all better. You know, we have vaccines for viral illnesses, yes, that are effective, but there are many viral illnesses that we do not have effective vaccines for. So I just want to bring us back down. Thank you.
Well, thank you for that, Dr. Gould. No, I think that you know, everyone knows we're taking this one day at a time with the coronavirus. Unfortunately, we don't know what's coming down the pipeline. As we've already discussed, the models can only help us with the incomplete, inaccurate data that we currently have. But something that we certainly do have the control over, whether if we don't have the control over what kind of vaccine might come out, and in terms of like the rate of scientific exploration with the production of a vaccine, something that we certainly do have a lot of ability in this country to work on, like Professor Darman was saying, is that we need increased capacity. I mean, we are the richest country in the world. We are the most powerful nation. We have like what was considered to be a very robust economy, at least in terms of GDP. Prior to the coronavirus epidemic, we have capacity, we have capability. We have so many companies, so many factories right now that could be producing the PPE that we need, that could be producing the ventilators that we need. Why do we have to be scrambling for this scarcity of resources in the country of abundance? Like that, I think is really, like Dr. Gould was saying, people have to die alone right now because there's just such a lack of PPE. Of course, it's going to go to the healthcare professionals. We don't have enough to give to the family members of patients. But why do we live, like, we're a rich country, we're the richest country in the world. What is the function and utility of living in such a rich country if we can't even create enough masks, disposable masks, for in the middle of a pandemic when we had months of lead time to do such a thing? And I wanted to talk about something that I just really want to talk a lot about the racial disparities that we're seeing right now. And so as we've discussed, and as Marty's pointed out, you know, Wayne County, 7th most cases in the entire country. And as we all know, Wayne County has Detroit, Michigan in it, which is a heavily Black population. And some Michigan data suggests that 40% of those who die from coronavirus in Michigan are Black. And some of these projections don't even include Detroit or Wayne County, where many of the Black residents in our state live. So I want us to just kind of unpack, why do we see this? Even though African Americans only account for 14% of the state's population, how does this speak to the larger inequities in our healthcare system? And I know we've talked about bits and pieces of this already, but I really just want us to focus on this for a little bit. So whoever feels free, take it away.
Well, this is something I think a lot of us have been thinking about quite a bit. And I think there's no question that disparities that existed, inequity that existed before the pandemic has, I think, come to the fore during the pandemic, so that people who have underlying health problems may be more likely to get sick. The poorer you are, the sicker you are, and vice versa. Okay, poverty and illness are mutually reinforcing. African American infection rates and mortality rates, I think we really need to very quickly try to figure out what is contributing to that. Is it just pre-existing health conditions? Is it also density of where people live? Is it a culture that really loves to hug people? Okay. I got mad at my daughter's girlfriend is an African, or not girlfriend, boyfriend is an African American. And he tried to hug me early on in the pandemic. I was like, don't. And he insisted. And, and his mom got really mad at him when he went to his brother's house and he wouldn't hug her just the other day on Easter. So I don't know. Is there a cultural thing? Is there a mistrust of the healthcare system? Is there we know there's worse access to care for African Americans. Is it something to do with the immune system? So we know African American women, for instance, have a much higher rate of lupus than white women. So, and we know something about how COVID in severe cases, sort of, it's the immune system kind of goes wacko. Okay, so you have the inflammatory markers are all way up, and that's a bad prognostic sign. So is there something like that has to do with it? Or, hypertension we know is a risk factor for worse disease, and hypertension and kidney disease. I think, Marty, you mentioned a shortage of dialysis units, and kidney disease is much more common in African Americans. So I think we really need to try to figure this out, and we need to try to figure it out soon so that we can do something about it.
Yeah, and I think I'm not a medical professional, so I can't speak to biology, but I think that you were framing this in terms of health inequities, but it's really political inequities and societal inequities much more broadly. We're talking about people, not only their own circumstances, but the circumstances of generations that came before them, can do things like dictate some of your opportunities and where you live. And so some of those factors, geographic and health the health factors that and health problems that those things feed into can contribute to your propensity to get COVID, and as well as thinking about the way in which you're treated, where you're going for treatment, and the capacity there. So there's very big factors here. And I think a lot of people will not be, unfortunately, surprised that these inequities that have lasted so long are still here. And in a time of crisis, we're seeing, the resulting differential effects of this disease.
Absolutely. No, I think that there's, like Dr. Gould said, there are many different factors that could be contributing. And as Professor Darman just said, what we do know is that there are one of those factors certainly is the existing health inequities in our current society that are across racial lines. And something that I think certainly contributed, at least from my perspective, in the coronavirus epidemic is that, like Dr. Gould was saying, in some jobs, you were not able to take sick time off. You're not able to take paid time off. And so initially, when there was a lot of concern about the coronavirus before the mandate from the governor, many people were able to work from home, but from many service-oriented jobs or low income jobs, unfortunately, if people wanted to stay home, they would lose their job. And so they had to go out and be participating in our economy in a face-to-face way, when that, as we all know, is increasing our risk for exposure, both in terms of getting it and also getting the virus and also transmitting the virus. So I completely agree with you guys on that stance. It's multifactorial. And something that we've already discussed as well, tangentially, is the fact that every state is dealing with different prevalence and incidence rates of the virus. So we have right now a decentralized response. Do you believe that some elements of a decentralized response are useful, or because of our interstate borders and because they are so fluid, do we feel like we need a strong centralized federal response? And I know we've talked a little bit about that, but do you guys have any final thoughts on that matter?
So I think it depends what kind of response you're talking about. So, for instance, I think when it comes to using the federal stockpile or responding to emergencies, or saying, okay, there's an outbreak, we need to help them now, okay, and that means we're not going to help this other place as much right now. That sort of thing requires a federal response. Okay, we're used to FEMA working after usually short-term catastrophes, hurricanes and tornadoes. California's fires maybe were a little bit longer lasting than that, but but this is nationwide. So how do you target the resources needed to the places that need it the most, when they need it the most, and respond quickly? That really has to be a federal action if you're looking at the whole country. Then within states, you can do it, within the state as well, but you can't just rely on the states, because we share a border with Ohio. And so I think actually the states banding together in these regional groups, they're basically trying to do what the feds should be doing.
Yep, and so I completely agree. That's a symptom of these states recognize that people flow across borders, and they've got to try to work together to figure this out. And so it's been strange to watch the federal response, because as a political scientist, normally when you study how states respond and how political leaders respond to crisis, they take the opportunity to talk up unity and try to bring people together. And you see in their rhetoric, in their speeches, and hopefully in their actions, the idea that they're trying to lead the country in a time of crisis and bring people together, coordinate a response. That hasn't really been the picture that we've seen from the federal leadership here, especially from Trump. And it's been more some discussions about states trying to put blame actually on states, put blame on other countries, put blame on the international organizations like the WHO, and less of that kind of very presidential style that we would expect from the president of trying to bring about national unity, in addition to having the kind of distributional policies that Susan was referring to. So you've seen a lot of leaders around the world do this kind of thing very successfully, and their approval ratings have gone up as a result, and they've taken on that kind of world.
Can I say, especially women leaders?
Yeah. Mm-hmm.
New Zealand, Germany.
Yeah, Angela Merkel would be a great example, and also she has a science background, so she leans into that very much. But I would say we haven't seen that in the US, and it's been a shame, because some of that messaging has been missing. It's a very important role for the federal government during a time like this to give people, give governors cover. So although the center is not dictating to state governors, you should do this, the center should say, here is our position and our guidance, and then state governors can use that and run with it, and it helps to justify the measures that they need to take in order to keep people safe. So a lack of a good, strong central message really does affect policy in states and what states can do, and it affects compliance amongst all of us. And are we getting the message that we should stay home and stay safe and try to help medical professionals and our health systems by not adding to the problem? So, yeah.
Solomon, I was just going to say they shouldn't, and like you were just saying too, Holly, that it shouldn't be, they're not mutually exclusive, right? A strong central response should be driving a very strong state, local, regional response, and coordinating that and organizing it and giving it the resources that it needs, resources that that whole system needs. And any government that can inject $1.3 trillion into Wall Street overnight certainly has the resources to manufacture, create, and distribute those resources that are necessary. And certainly maintain the strategic stockpiles, which they weren't doing. They let the contract run out to do the preventive maintenance on the ventilators. So when they did send them out, they didn't work, and on down the line, not maintaining even that section of the CDC that responds to pandemics. And it's just like the dominoes just go flip, 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 flip all the way down. So you can see how the lack of that response is driving the chaotic, discoordinated response on the local level, and then in the negative, see that a strong central response could be driving a much more positive response at the state, local level.
I say that I think one of the things that we've also seen in this pandemic, yes, we've seen some of the usual divisive rhetoric coming from lots of different places, but we've also seen a lot of people helping people. And, how can I help older people in my neighborhood, or the kids who aren't getting their lunches, or, sewing masks for other people to use? And that's what I wish we had more talk about from our political leaders, all political leaders. Solomon, take note. And that this is, there are a lot of things that make America a wonderful place, okay? We're smart, we have all kinds of innovative people and businesses and scientists and things like that, and that's great. But and some of them went to work using their 3D printers and all kinds of other stuff to try to make up for a lack of supplies. Those stories we need to highlight, okay? The stories of the businesses who keep paying their employees even though they're not selling anything, okay? And they're happening too, not all of them, obviously. Large and small employers who are being loyal to their employees. I think we need to highlight that. I just, the divisiveness, I don't think it's helping us locally, regionally, statewide, or nationally meet the challenges of this. We need to be in it together.
I completely agree. And I think, like you said, we are seeing so many stories of people stepping up, companies stepping up, who are, who might have had a shutdown, but who are still making sure that their employees are taken care of, who are stepping up to create the PPE, creating the masks, creating what people need in this time. But unfortunately, we have to have stories like that because of a lack of a strong centralized response, where in a country like we've seen in other countries where there is a desirable response, we don't need to have individual stories of heroic companies or individuals making up for the lack of a government response. And I want to talk about the administration. So the current administration has halted funding for the WHO, as well as previously changed levels of funding for the CDC and different pandemic response teams, as we've discussed. Do you feel that factors such as these have as big an impact on the pandemic as some perceive? And what other things has this administration and past administrations done to weaken our health infrastructure?
I want to say I want both of those things. I want both individual kindness and communal solidarity, and I want a strong federal response. I want all of those things. Yeah, and so the same thing goes for thinking about us as part of an international community. So I'll just say I do some work with the WHO in Europe, and so I have a very clear opinion on this point, but I think that the work that they do is important. They do a lot of important work trying to coordinate countries' responses, and as well as doing work on health system strengthening. And so they don't always have a perfect record in how they behave in each of these different pandemics, but I think in this one, the WHO has done a lot of good work. And I think it's a shame that the US administration has seen fit not to support the WHO at this time, and in fact to not feel part of that international community. This is a pandemic, and I think we need some of that solidarity, not just in our communities and those good stories of people reaching out to each other. We need to understand that as countries we have to work together, because that's how disease spreads. I mean, on the very basic level, that coordination is important, but also it's important for thinking about who gets access to essential medicines, who gets access to, if in the future we had any form of vaccine. I think that would be, that's something important to think about. And if we're competing with each other and blaming each other, I think we all lose out, actually. Yeah,
for sure. And like the very real ramifications of that, as we've seen in terms of cases and deaths, and a lot of blaming and finger pointing going on, unfortunately. So I think, this has been a fantastic discussion about coronavirus, where we stand, and what we need, what we have seen from a federal response, what we would like to have seen from a federal response. I want to bring the conversation now to Medicare for All, which is the other big point of discussion of our town hall. So something that we were talking about previously is also the racial disparities that we're seeing in the coronavirus. And a Medicare for All system would create equality for treatment for Black and Brown people. And that is part of the reason that we want a Medicare for All system, or at least that I'm certainly advocating for a Medicare for All system. And there are many other reasons too that we want that I believe a Medicare for All system would help us make the outcomes in the middle of a pandemic more equitable, as well as just improve the health of our nation overall. But for our viewers who are less familiar with Medicare for All, Professor Jarman, do you think that you could give us a quick breakdown about Medicare for All and how it would work just to ensure healthcare for all people in our country?
Yeah, sure, of course I can. Sorry, I'm fighting a little bit with the sun here. It's actually sunny in Michigan today instead of really snowing. The question, what is Medicare for All, is an important one, because different people see it different ways and different people formulate it different ways. And so actually one of my main points is to think about, we use all these labels like Medicare for All, we talk about single payer, we're talking about a public option. And I think we have to be quite careful what we're talking about here, because some options will be better for others, for people. But I think the key principles remain the same. As I said earlier, we want to make sure everybody can access healthcare. We want to make sure it's good quality healthcare, and we want to make sure that it's not going to cause economic hardship to do that, to access that care. And when I say care, really I'm thinking about, in the broad definition, prevention, public health included in that definition of access to healthcare. So you could say, if you start from the basics, Medicare is a government program. It provides healthcare to people over 65 and then some other categories of people with particular health conditions. The basic idea behind Medicare for All, and in some of its different formulations, is to open up a program like Medicare to allow more people to access and enroll in this type of care. But like I said, there's a few different ways to do that. Some plans, particularly the one most recently discussed and promoted by Bernie Sanders, would essentially really close down the private insurance market and make the government really the single payer here. So hopefully you can get the basic idea behind this. There are also, it kind of connects with our discussions about talking about a public option in health insurance exchanges, because that could, one of those public options could be to allow people to enroll in Medicare. So there's hopefully more common ground amongst these different health proposals than you might think. I do want to be careful though to think about how we talk about the benefits of Medicare for All, because there are some difficult decisions that might have to be made. And so when you look at countries around the world, you see that they do a couple of things that seem to make sense in terms of having better health outcomes at less cost than we do. One of them is really having better ways to control prices within the healthcare system. And another one is a better way to bargain in big volume for very expensive things like pharmaceuticals. And as we've already mentioned, a third possibility is that by having moving to a single payer system, moving to a system where the government is really managing most healthcare, you would reduce administrative costs within the system. So those are some potential advantages, but in order to get those advantages, we do have to think very carefully about not just giving the government the tools to do this, but following through with making sure that the government is actually able to use price controls, able to use its bargaining power, and in ways that don't cause negative adverse consequences for people, either medical professionals in the health system or patients or society more generally. So healthcare is a tricky thing, but hopefully we can learn some lessons from other places and how they're doing it. Wow, that was a lot of information in hopefully 1 minute.
Well, it certainly is a broad topic. Medicare for All is a completely different healthcare system than the one that we have in the United States of America, but I think you did great justice by hitting on some of the very important key points. And so, we have about 38 minutes left until the end of the town hall. I do want to save about 20 minutes for question and answer. So I want us, I want us to have a discussion, but I do want us to elaborate a little bit about Medicare for All before we kind of get the question answer section. And there's a couple topics that I want to make sure we hit on. So I might kind of try to moderate a little bit more in this point of the conversation. But right now, something that a lot of people like to push back on when we talk about Medicare for All is that they like to say it is just not feasible in the United States of America. And so I wanted to ask our panel, how feasible is it in the United States, and how does it work for other countries? And there are many myths as well, myths of wait time, lack of funding for hospitals, and diminished pay for doctors. So can we talk about just the feasibility and also how some of these what I perceive to be myths of Medicare for All, let's address some of these concerns that people have.
So let me take on a couple of things. First of all, I think sometimes when people hear about Medicare for All, they say, well, no, that will eliminate competition and therefore the quality will get worse. And actually, I'm going to suggest that, and I know Holly, you were intending it this way, but when you said Medicare provides care, that's not completely true, right? They pay for care provided by others. All right, Medicare pays for care provided by others. And so what you're talking about is a system where there is a single payer that can work in lots of different ways, by the way. But even Medicare now, which is a single payer for people over 65, people with kidney disease and some other conditions, you could have a Medicare Advantage plan that is different and sort of an HMO, PPO type thing. But competition would not be eliminated. You would still have competition on the part of people who provide the care, which is really where you want it, right? Okay, people aren't really good at at deciding which insurance company is best. So the competition between insurance companies is, you know, the employers tend to make those decisions, not individual people. But people are sometimes a little better at deciding where they want to get health care or what, you know, what doctors and hospitals they trust. So I think the first myth is that competition would go away. That is not true. Okay. The second myth is about wait times. And no, actually, it's not completely a myth because yes, places with universal coverage, such as Canada, the UK, other places, yes, they have wait times. But guess what? So do we. Sometimes they're really long. I can't get a patient in to see a neurologist for almost a year sometimes. That's a wait time, even if they have private insurance. Okay. So, you know, everybody has wait times. And sometimes the question is, well, okay, do people who need care urgently get it urgently? And do they face financial barriers to getting it urgently? And the answer to that question is yes in the US and no in lots of other places, right? So there are a lot of different ways Medicare for All could be created, right? You could just take the current Medicare and just say, okay, now everybody has it. All right, that's one way of doing it. I don't know how much people know about Medicare, but Medicare doesn't pay for everything, right? If you're hospitalized, you still get a big bill unless you buy supplementary insurance, Medigap insurance. So if you're going to have that Medicare for all, then you might have to recognize that people are still going to have some pretty big out-of-pocket expenses. Medicaid for all might be a better idea, but people don't like the sound of that at all. It doesn't have a good ring to it. It's probably a better policy plan. Okay.
For
So
sure.
one myth was competition. One is wait times that we have here already, and you know, other things that happen sometimes, like doctor strikes or whatever. I mean, yeah, it's
some of the things about wait times are to do with other factors, not necessarily the payment structure or who the payer is, right? So other things that governments do, and they do well in some areas and they do very badly in other areas, like setting targets and things like that, really do have an effect on wait times, as well as whether they're managing the professional workforce and the capacity in the system well. So yeah, it's the wait times thing is largely a myth, and it's not, doesn't really necessarily directly relate to the overall payment structure you have in your healthcare system. But the one of the issues with any US publicly funded healthcare program will be enrollment and the burden of that. And so one of the things to consider is it how, in terms of program design, is how easy is it for someone to get their healthcare, to get enrolled, to stay enrolled. We have a lot of programs, social programs and health programs in the United States where it's really difficult and burdensome to get your care, even when it is a publicly provided plan. So one of the things we would want to look at is that burden, which falls most proportionately on people who are time poor, resource poor, and may not have the information or advice that you need. You know, we only need to look at the ACA and how hard it has been in some cases to get people enrolled, and the amount of support that some people really do need to help them make those decisions and go through that process. So we need to think not just about the program as it is today, but about some other ways in which it could be improved in order to design the best program that we could.
Yeah, I completely, yeah, for sure, 100%. And like we have seen, a social program is just as good as the amount of people that you can bring into it, right? And if you have a program for people, but no one can access it because they're too time poor or too resource poor, like you said, and we've made it extraordinarily burdensome with so many forms and such different and so many processes for people to be able to actually become part of that program, well, then like how many people are actually benefiting from that social program. And something that we have seen in other countries that we really appreciate And also for Medicare, you know, you don't have, like, when you turn 65, you have Medicare. In other countries, you just have healthcare. Like, that's just, you just have it, right? And so the plan that Bernie Sanders has proposed with Medicare for All, it is not just saying, let's take our current Medicare system and expand it to everybody, you know, where everyone would still have huge out-of-pocket expenses. But it's actually, it's taking the brand of Medicare and just saying, let's provide healthcare for everyone. And so that plan that I support, that many progressives supports, that Bernie Sanders has been putting forth, says, let's create a plan that has no premiums, copays, or deductibles, that covers healthcare, dental, vision, as well as your, you know, doctor visits and hospital visits. Because the goal of this plan is to create healthcare that everyone has, that is not unduly financially burdensome, as Professor Darman was saying to start off our conversation. And because, as we know, in this country, we have tens of thousands of people every year who declare bankruptcy because of medical bills. We have tens of thousands of people every year who die because they're not able to get treatment that they need. And we have tens of millions of people who don't have health insurance at all. So we would want a system that where people are still not getting these huge out-of-pocket expenses that might exist in the current Medicare system for people ages over 65, but in the Medicare for All system, we would not want anything like that, which is how they do things in many other countries as well. And I think something that, you know, especially now with Vice President Biden being our nominee, right? His plan is a public option. So he's not in support of a Medicare for All plan. But the progressive left in particular still is very much in support of a Medicare for All plan. And so I want to ask you guys about, you know, the differences between like a public option and a Medicare for All plan. Can you outline the differences between those? Like whoever wants to take this one.
All right, I'll take a stab at it. So basically, I'm not sure there's just two options. There have been a variety of things proposed. With a public option, that is, you know, you can keep your private insurance if you like it, or you can enroll in a Medicare-like plan using the exchange, the Affordable Care Act exchanges. I think that there are countries that have systems that mix private and public pieces. So Germany, for instance, is one of those. Switzerland actually has an interesting system. They have mandatory health insurance, but quite generous, depending on what canton you live in, subsidies for purchasing that health insurance. And then the hospitals and the workforce are provided by the federal government. So it's a mix, okay, of public and private. A public option is basically, okay, you can purchase this if you would rather have that than, you know, some private insurance that may or may not be offered to you either on the exchange or through your employer. And Medicare for All means everybody gets the same thing. Well, maybe. That's maybe there's lots of different varieties to that, right? You could have a Medicare for All plan that says, okay, you can join a plan as long as it includes X, Y, and Z benefits, and here's the voucher for that, and blah, blah, blah. So I don't know, Holly, you may be able to better explain this, but there's a whole bunch of variations on the theme.
Yeah, we could talk about the variations forever. I think, though, like one of the key conceptual differences is that the a public option would maintain that part of the ACA which set up public health insurance exchanges. So if you can think of these like a virtual shopping mall, the idea is that it should facilitate people who want to come and choose a plan, and the one of the main tenets of that was the idea of choice and having lots of different things in the exchange. In practice, there's a bunch of problems with that, as we found out, which I won't go into too much. But that would maintain that kind of virtual supermarket, but one of the options would be a public plan, like, for example, Medicare. So that's quite different than Medicare for All plans that have been proposed, which largely, not in all cases, but in many cases, propose closing down or really peeling back on the private insurance market. So that's a really different decision, and it's has different implications. But you can see that one argument that's made for doing Medicare for All rather than a public option is that insurers would continue to be able to lobby against the public option probably, and that some of that would get rolled back over time.
Right.
We really don't quite know how all of that politics would play out. But there's been pushback against the insurance industry for that reason. And so some people have used that as the logic for why Medicare for All would be better than a public option. And other people have said, well, the Medicare for All option would be too disruptive, and that it would be of a scope cutting back costs that we haven't seen anywhere in the world, really, because our healthcare costs are so high. And so, the people who argue for the public option over Medicare for All really tend to say Medicare for All will be too disruptive. And so some of the discussion has focused around, is it possible to do a Medicare for All plan, bring it in gradually, and what would the disruption from that be?
Yeah, absolutely. And I think on that note, with Medicare for All versus public option, I think some people, when we see public option, right, like I visualize it the same exact way as you, Dr. Jarman, or Professor Jarman, which is that we have there are options for health insurance, and then the government is just providing another option, and you can pick that option or you can make other ones, but you still have to pay for it. So is that just kind of another healthcare plan that you would have to pay for? And then I think some people are concerned about, well, what if you don't have enough money to pay for that plan? Are you in the same exact position that you were in with just being not able to afford healthcare to begin with the other plans that are often very expensive? So is that a concern that people would have with this plan?
Yeah, so when I'm talking about price controls, really that's the benefit of doing a Medicare for All plan is you might have better tools as a government if you use them properly, and if they're properly designed to try to control prices. With an exchange doesn't necessarily mean, as we found out, that there will be a nice, wonderful variety of stuff like you find in the supermarket. You can have an exchange which has very little in it. And a lot of those options can still be very unaffordable for people. And so that's a huge problem that we have to overcome. Yeah.
One of the things that we've heard from people about purchasing insurance on the exchanges is that they buy insurance that basically doesn't benefit them at all. Unless, of course, they get very sick, but because they have a very high deductible, for instance. And so I think one of the things that we would need to think about in a Medicare for All plan is what sort of out-of-pocket expenses would be faced. So Medicare right now, for instance, if you don't have supplementary insurance, whether you buy that or it's provided by Medicaid, for instance, then you have a lot of financial responsibility for medical care, outpatient or inpatient. And the same thing with, for instance, pharmaceuticals. You have to buy into that particular part of Medicare at a heavily discounted rate, by the way, for the most part, but that's another story. Old people have lots of political power. But what sort of out-of-pocket expenses would be faced by people with a Medicare for All? One of the things I heard from Bernie was that nothing. It would always be free. I'm not sure that's a really good policy solution. I think, I should pay something when I go see the doctor or fill a prescription. And do we charge the same amount for someone who is going for a vital, important visit to manage their, blood pressure or diabetes as we do for the person who's going to a dermatologist for their acne? And I think the answer to that should be no. These are not easy questions, and how we decide on, as you said, Holly, prices. Prices paid for drugs would be an enormous piece of savings, I think, in Medicare for All, as would administrative expenses. But I think we should be very thoughtful about what sort of out-of-pocket costs would be faced by people when they go to seek care.
Right. And I think that it often, ultimately comes down to what is our policy goal, and how does that relate to our values and the kind of society that we want to live in. And when we see the kind of societies that other countries have been able to produce through their through creating policies that enact their values by saying that healthcare is a human right, everyone should be able to see a doctor if they're sick, everyone should be able to get the medicines if they're sick. That's the kind of policy that we want to design. And I think Bernie Sanders was saying that you would have up to $200 in out-of-pocket expenses for prescription drug shots every year. So there is a little bit of money that a consumer would be paying towards their own healthcare in that sense. But I want to transition to our last question before Q&A, which is how could Medicare for All close existing gaps in the healthcare system, or possibly lighten the burden of this pandemic right now? And I especially want to hear from Marty about how Medicare for All could help lighten the load or improve the healthcare system, close existing gaps for nurses and healthcare workers.
Mm-hmm. I think that Medicare for All would have the biggest effect actually for patients, right? You talked about all those health disparities, the racial and income determined healthcare disparities, and that a lot of that is due to underlying conditions and patients not being able to treat those underlying conditions over a very long period of time, in addition to the aspects that the other speakers were bringing in, inadequate housing, just the stress of not being able to pay your bills and not knowing whether your kids are going to get, proper daycare, et cetera, et cetera. All those things wrapped into one. Being poor is really, really bad for your health. There's just no way around it. And being able to support preventative care and people managing their healthcare needs over a lifetime with Medicare for All would have tremendous effect on hopefully narrowing those gaps in and those disparities, healthcare disparities. So I think that it would be a huge step forward that we can't even begin to contemplate now, like what the world would be like on the other side, and even like 20 years out on the other side. The other thing has to do with the financial basis of so many hospitals, coming in large part from Medicare and Medicaid. And we've lost, over 100 rural hospitals in the last decade. I think that New York City itself has lost like 20,000 beds over the last decade. So Medicare for All would sort of balance the financial bottom line for so many of these institutions that not only in the urban centers, but in the rural centers, treat a very low income population. And we've already, some of the problems that we're facing right now in the COVID crisis are a direct result of the Trump administration cutting bit by bit by bit the ACA, and increasing, and political opponents of Medicaid, and particularly Medicaid, actually increasing all those hoops and barriers that Professor Jarman was talking about in terms of people actually being able to access a benefit that by law they have, but they can't actually jump through all the hoops to get it because political opponents at the state level have enacted and erected all these barriers and things that people have to do, whether it's, showing that they are looking for work to be able to get Medicaid, et cetera. So the decreasing the income of those institutions, of the hospitals, has led to shortages of staff and equipment to begin with over which now the COVID crisis has been laid. My hospital has 100 fewer nurses than we did a year ago because of those cuts and because of the demands of the for-profit. Even though I work for a not-for-profit hospital, it has to compete in a for-profit industry. And so it has to like meet the bottom line and make its bonds, please its bondholders, et cetera, by keeping everything to the bone, not having anything in reserve, managing the staff on a 4-hour basis, like sending nurses home every 4 hours if there aren't the patients at that minute in the beds, even though they know they have patients waiting in the emergency department. They know they have patients waiting in the OR to come out, and still they're staffing to how many patients are in that bed at that minute. And that's just doesn't work. It doesn't lead to good outcomes. It doesn't lead to happy patients or happy healthcare providers. And so on both those levels, for the patients being able to acquire the care that they need to sort of stabilize the finances of the institutions, and then allow those institutions to have the staff, the equipment, and supplies that they need to take care of those patients. In all those ways, Medicare for All would be a ginormous step forward. But as Dr. Gould pointed to earlier, it doesn't change it changes the funding. It doesn't change the costs. And so you would have to go further and enact further change that eliminates those like the sort of capitalist for-profit drivers of the system in order to change the cost in a really big way. You could change it to a certain degree by allowing negotiation over drug costs, which is something that the ACA specifically disallowed. So you could bring that in to this plan. But I really feel like Medicare for All is Medicare for All. It's the Bernie Sanders and Pramila Jayapal's plans. And that all those other like kind of plans, I call Medicare for a few more, because it's not Medicare for All. I think I agree with Professor Jarman that we need to be clear about what we're talking about. And Medicare for All means all in, nobody out, but it does have to be improved Medicare for All. And I agree with how you phrased it, Solomon, that using the brand of Medicare, because there's some services that are absolutely necessary that people over 65 just don't need, right? Prenatal care is like the most common example. So you would need to add services to this. And many of them are part of Medicaid for people with disabilities who need to stay in their homes. Those services that are provided, the home care services that are provided through Medicaid, are essential to maintaining an independent life in their own homes. They would be forced into institutions without them. So when we say Medicare for All, what I mean is the Bernie Sanders and Pramila Jayapal plan that sort of brings in a lot more services than what Medicare right now includes, and it decreases that cost. It's not the 80% that Medicare right now includes.
Right, absolutely. And I think Marty, you really took us home with that one, which that Medicare in so many different sections of healthcare in the economy would dramatically improve things for rural hospitals. It would improve things for patients, for people of color, minorities, low-income people. It would be a policy that has widespread ramifications for all different sectors of participants in our healthcare economy. So I, and on that note, and that note of the fact that the bill that you support and that I support is the Medicare for All bill by Bernie Sanders and Pramila Jayapal in the House and the Senate. I support that because I believe everyone is entitled to quality healthcare as a human right. And that's why I'm in favor of that bill, and not any of these like watered down Medicare for All who want it, or Medicare for All who might infect me, because like now people want people to have health insurance because of the pandemic, so I completely agree with you on that front. So we have about 10 minutes now for question and answers. So we're gonna have to lightning round this one, guys, because we have a lot of questions, and so I'm gonna direct the question to one panelist, and then we'll have like 30-second response. So we'll be like in and out, So like we'll get our sound bites in for the day. So this first question is for Marty. What are some ways that we can support nurses right now during the pandemic, and what legislation decisions can we support that will help people like you?
Yeah, so I thank everyone for all the help that we have gotten, because people have been donating food and coffee and supplies and all those things, and we're super grateful for all those things. I think the main things people can do right now is not get sick, and that's not a simple question. I know that speaks to the social distancing and the stay-at-home orders, and people need what they need in order to stay at home, right? They need an income, they need relief from rent and mortgage, all those things. And so applying the political pressure that would get those things out of government right now, so that people can stay home, that they can stay well, and that you stay out of the hospital.
Absolutely. Thank you for that. Dr. Gould, Lauren asks, testing and contact tracing, this is so clear. Why can't we do this? Why are we not doing it? How can we roll this out in Michigan in spite of the inaction of the federal government?
Oh, well, and I'm supposed to answer this in 30 seconds. Okay. So
I'll give
first,
like 20 seconds.
yeah. So, I mean, the supply of tests has been an issue from the beginning. And I think there's different kinds of tests, by the way. You can test for antibodies as well as test for the virus itself. And if you just test, but you don't contact trace, that is trace down the people they've had contact with, and that requires personnel. Now, there's a lot of people out of work right now who could potentially be trained to do that, but it's not a really simple job, and Holly probably knows more about this than I do, but I think we could potentially use community health workers. We could potentially draw on some other elements of the workforce for contact tracing. So yes, it needs to happen, but the reality is we just don't have the supplies, and the supplies in terms of what's missing has varied over time, whether it's, the swabs or the reagent, or, I think we have the labs, that's not a problem. But the other thing that is a problem is that particularly at the federal level, saying, okay, this lab, go here, take care of this population, and this lab take care of that population. That hasn't happened. That really needs to happen. And it probably won't happen. So I think it needs to happen at the state level. And I believe that it's probably being worked on as we speak.
Yeah, there are a lot of things that need to happen. In other words, no, but I completely agree with you on that. Dr. Jarman, given the many intersecting issues, race, gender, identity, poverty, etc., what are some of the actions that can be taken both institutionally and through movements to overcome these struggles, particularly in how they affect people's health outcomes?
Oh, geez. 30-second answer, right? I think
we'll do 45 seconds to a minute on this one.
Well, so easy guide to political change. Talk, learn to be articulate about these issues. Talk to your friends and family, social distancing still, but communicate with others and talk about these issues and raise them. See if you can mobilize, see if you can join a group that's pushing on this issue. Don't be afraid to speak out, because your voice might be the voice we need to hear right now. Social change only happens through mass political mobilization, persistence, and then people on the other end who are willing to stand for government, who are willing to stand up and represent their communities or represent us as a state, who have thought through these issues and are connected to those communities, understand these problems, and are willing to try and put that into policy, take a risk. Yeah.
Well, I think you did a fantastic job in the very small amount of time I gave you to essentially say how are we going to fix our entire world in a nutshell. But But that is a great point that I do want to drive home, which is we cannot expect change in our society to be made while sitting on the sidelines. And that's a big reason why I decided to run as a medical student, taking a leave in the middle of my medical education to try to fix some of the problems that I feel were so badly being handled. And something that fantastic that has happened while I've been working on this campaign is that we've been able to have so many conversations with so many people and talk with them about some of the big problems that are going on and how things could be better. And I think really getting involved in groups and having conversations with your friends and family, it can't happen without that. It absolutely can't happen without that. So another question is, if Medicare-for-All was implemented, what would you propose be done for people who would like to keep their current medical insurance provider? I know a lot of people like to push back on Medicare-for-All saying, I like my insurance just fine, thank you very much. So what would the message be that you would say to those people? And I'd like to direct this question to Marty.
There's 17 million unemployed people in the last 3 weeks, right? There goes your insurance right out the window. I mean, this would this would make your health coverage independent of employment, and would give people much greater latitude and the ability to choose jobs that they liked more, not just based on what their what the benefit level was that job provided. It would allow people to push back on their jobs, not worrying about losing their jobs. They'd be able to organize like essential workers now, trying to organize for the PPE that they need, grocery workers. They need that job. And so they don't push back maybe as much as they would want to about getting what they need to be safe on the job, because they need the health benefits that come through that job. So I can understand people feeling the security of what they have and that it's a risk to jump, but the system we have is not working. We have wait times, we have unbelievable costs compared to the rest of the world. And this isn't the last pandemic that we're going to have to deal with. We know that to be true. So I guess just for that person that loves their health insurance, I'm glad that they love their insurance and that it's working well for them. A lot of other people aren't in that position, and they may not be in that position by next week as well.
Yeah, that's a comment that I hear quite a bit, where people are like saying, I like my health insurance. I think that I should just keep it. I don't want to risk losing something else. And that's also something that more moderate candidates in this race, like Vice President Biden, have said, like, to play to the healthcare benefits that people have won through collective organizing, like unions and teachers, or collective bargaining. They say, like, you've worked so hard for these benefits. We don't want to take it away. But like you said, Marty, you can lose your job like this, and then you lose your healthcare like this. And do you like your health insurance provider, or do you like your doctor? Do you like the ability to see the doctor that you have, to be able to get the tests that you want at right now, what might be a reasonable price, but under Medicare-for-All would be totally covered? Would you like to have an insurance provider that would make your premiums, copays, and deductibles $0? So that's kind of, that I think is the framing that we need to use when we think about people's concerns for Medicare-for-All. And I completely echo everything that you just said. Actually, it's really interesting. Quick aside, I know doctors who are working jobs that they don't like as physicians, and I'm like, why don't you quit? Like, you probably made some money that, like, you've saved away or something. They're like, it's the benefits, it's the insurance. Like, I'm the provider for my family for our medical insurance. What would I do? Like, my child needs all of this medical treatment, I have to work this job. Like, even, it's not just like, it's literally everyone in our society feels trapped because of their health insurance benefits, which is so unfortunate. So it's 6:59. And so I think it's time for us to wrap this thing up. But I want to thank all of our panelists so much, Marty, Holly, Professor Jarman, and Dr. Gould. Thank you guys so much for taking the time. Honestly, this was a fantastic discussion. I learned a lot from everything that you guys I have to say. And I think you guys brought a really, really great perspective. You played off of each other very well. And everyone had a lot of very valuable things to say. So I want to thank you so much for taking the time. I want to thank all our viewers for taking the time to learn about Medicare for All, learn about the coronavirus pandemic and how Medicare for All policy would affect that pandemic. And also, if this is something that you care about, I'm sure we have people who are viewing across the country. Please get involved in a local progressive race that you have going on in your state or in your county or in your congressional district, and help elect people who will be champions for Medicare for All up and down the ballot. Because as we've seen, and many of my supporters and many people across the country who are part of the progressive left were very saddened by Bernie Sanders dropping out. But this movement is bigger than just one person. It's a movement that encapsulates so many people in our country who demand a vision that works of America that works for all people, and Medicare for All is a huge part of that vision. So this movement is bigger than all of us. So please get involved. If you want to get involved with our campaign in particular, you can go to solomonrajput.com. During the middle of a coronavirus, all donations are even more valuable. So please do help us. With donating, or if you are a student, if you're a high school student or a college student, please consider applying for our internship. It's a fantastic way to get involved. It's a lot of fun, and it's a great, and honestly, we're one of the only remote internship opportunities in town in the country, really. So thank you so much, everyone, for taking the time. Honestly, this was our best town hall that we've ever had, and I really appreciate everyone's time here today. So thank you, everyone, and yeah.
Thank you for having me. Bye-bye.
Bye-bye.